Yes, please. So please type your messages in the chat box, guys. All right. So I think we are good to go. Yes, so just waiting you guys giving me a thumbs up that the audio visual part is okay. Okay, fair enough. So I think now everything is perfect and I think we are just good to go. Thank you for letting me know. All right. So good evening to everyone. I'm Dr. Mukul Mohindra, your orthopedic instructor, and this is a special recall session, where I'm going to just analyze the orthopedic exam, the orthopedic questions you all guys had to face in the FMG exam yesterday. So orthopedic part was very very simple. If you had attended the classes and gone through the notes, I think it was just a cakewalk. Around 10 questions came from orthopedics, and 10 is a significant number. And the biggest opportunity I think these questions offered to you was 10 on 10. So if you were prepared with the subject, you could score 10 on 10. So it was all about the basics. And just in case some repeaters were giving the exam, let me tell you, just in case you guys were thorough with the repeat questions, trust me, the exam was simply very easy because questions did change a little bit, but the topics were almost the same topics that trouble you every year. So I'll just quickly take you through some of the questions. This was a very simple one. You have to identify the splint, and I think so that this picture was there. This is a very popular splint that is known as the Bowler bronze splint. So that was the answer. But it's been a very usual tradition, that pictures of splints come up and you guys have to answer it up. The splints that's shown in front of you. Last year this picture had come, the Dennis Brown splint, and this year the BB splint. So during your classes you must look at these pictures very carefully. Splints are integral to the orthopedic practice. They help you uh, in many scenarios, tackling deformities, cutting down pain, mobilization of patients. So you must be having good knowledge about these splints. But yes, for your exam, in case this picture was there, this is a BB splint that is very popularly used in orthopedics to immobilize lower limb fractures. So it is used for giving traction and maintaining immobilization in lower limb fractures. Okay, then I think this classical X-ray was there. That sunburst pattern was visible. Some people call it sun reappearance, some people call it sunburst appearance. So it can be sunburst or sun reappearance, which is synonymous, same thing. So I think this kind of a sun reappearance was visible and you were supposed to pick up the diagnosis, and I think that needs no discussion at all. This is diagnostic almost for osteosarcoma. Well, let me tell you, although this is diagnostic for osteosarcoma, but this can be seen in other malignant tumors of bone as well, like Ewing sarcoma. Okay, so you had to go through all the choices, but yes, if the age was say around 17 years, the chances of this being osteosarcoma are high, because age is another thing that may give you a clue. If you talk of osteosarcoma, there is a bimodal age difference, presentation. So you find it in young age also and old age also. So you find it around that 15-20 years age group also, and you find it around 60-40 years age group also. So this age would also fit in into osteosarcoma. The sunburst pattern would also fit in into osteosarcoma. So likely this was the answer to this particular question. Now, some people have been a bit confused about this one, that there was some kind of an X-ray where you could see this shoulder joint dislocated, and you were supposed to pick up the diagnosis. And yes, guys, please just feel free to correct me, to give your inputs, or to add on if something else was there in the exam, because you guys have all appeared. So your feedback would help me improve my conversation with you and give you more of information. Okay? Yes, your chat is visible to me. I can go through your chat right in front of me. So anything that you guys to add on, please just feel free to put it up in the chat box. All right. Now, this is a dislocated shoulder. I hope you can see this glenoid. We call this as the empty glenoid sign that tells us about a dislocated shoulder. Now, this bone is dislocated from the glenoid, this humerus, but X-ray is a two-dimensional thing. So this bone could be in front of scapula, it could be behind the scapula. So from just an AP view, it is very difficult to say whether it is anterior or posterior dislocation of the shoulder. So this is certainly a dislocated shoulder, but how to pick up anterior or posterior, I'll tell you. By and large, what you see more commonly is anterior dislocation of the shoulder. That is more common. Okay. But let me tell you, rarely you can also have posterior dislocation of the shoulder. And posterior dislocation of the shoulder actually gives you a diagnostic sign that is called the light bulb sign. So in posterior dislocation, the head will go back, and when this head goes back, it starts resembling a light bulb. So if the light bulb type picture was there, it was posterior dislocation of the shoulder, and if it was this empty glenoid sign, it was anterior dislocation of the shoulder. So that is how you have to decide between the two. I think the answer was posterior dislocation of the shoulder, because as per some students have been telling me, they were able to identify the light bulb sign. Now this is a very easy one. Patient had an RTA, femur shaft had been broken, and there were more than 48 hours after the injury, and you had to pick up what was the diagnosis. Patient was in that respiratory distress. I think the unanimous choice was fat embolism syndrome. Well, fat embolism syndrome would at least take 48 hours to occur. So if a femur fracture patient, he's feeling dyspneic, he's collapsing, in less than 48 hours, it is generally because of shock hemorrhage, because femur fracture leads to heavy blood loss. Head injury could also be there, that could lead to patient going unconscious and problems in this area, but then some kind of a history of head trauma would be there. Then respiratory distress would not be that prominent. Getting it? Now pulmonary embolism is a scenario where the history is generally prolonged for more than at least 7 days, because here you have a sedentary patient developing DVT in the legs, and then venous clots would go into the lungs. That is pulmonary embolism. So the time frame was a bit important here. After 78 hours, 48 hours, sorry. So after 40 to 72 hours, till this 7 days, fat embolism syndrome is like very, very peculiar. So generally, fat embolism syndrome would start around 2-3 days, and the period would continue to around 7 days. So this is the risky zone for fat embolism syndrome. Okay, when you have to consider about fat embolism syndrome, and it's generally associated with some major bone fractures like femur shaft fracture. Now I have received mixed kind of feedback on this one. Yes, yes. So anyone watching can give me the feedback also. So some people say there was a question that there was a deformity visible in the fourth and the fifth finger, and it was almost like a medial sided claw hand. And you were asked about the nerve that has been injured. So if it is medial claw hand, it is ulnar nerve that is injured, and this is how a medial sided claw hand would look like. Now, clawing is not just seen in ulnar nerve palsy, it is also seen in a combined median and ulnar nerve palsy, but here you have a complete claw hand, total claw hand. So it is all the four fingers showing you clawing. And mind you, median nerve palsy, there is no clawing at all. So when you talk of clawing, it could either be ulnar nerve palsy, medial two digits involved, it could be both median and ulnar nerve, all four fingers involved. There is nothing like a median nerve palsy leading to an isolated median nerve palsy leading to claw hand. Clear with that? So I hope you are clear with the reasons behind claw hand. And yes, some people are also saying that there were some more questions on median nerve, like maybe there was a picture like this mentioning about these 3.5 fingers having some numbness or some sensation issue. Okay, so that was where median nerve was involved, or some people are saying there was some problem with this holding of the book. I think you might have heard about that very, very popular froment sign. So patient has median nerve palsy, you ask him to hold a book like this. You ask him to hold the book, and he is unable to hold the book. Oops, sorry, I would just correct myself a little here. Just correct myself. This is not seen in median nerve palsy. This Froment sign is seen in ulnar nerve palsy. So some people say that there is some kind of a picture like this. You ask the patient to adduct the thumb and hold the book. He would flex the thumb to hold the book. This flexion of the thumb is Froment sign. So patient is trying to adduct the thumb, hold the book. He flexes the thumb, hold the book. That is Froment sign. And this is again seen in ulnar nerve palsy. So in case this 3.5 fingers area was there, median nerve was involved. In case this Froment sign picture was there, ulnar nerve was involved. And in case there was a claw hand on the medial side, ulnar nerve was involved. Radial nerve we are already very familiar. The classical thing you find with radial nerve palsy is a wrist drop, and I don't think that picture was there. So I hope you are clear with these MCQs also on nerve injuries. Now this was almost like you know something where examiner is just throwing marks on you. Low calcium levels, low phosphorus levels, high ALP levels. So you very well know vitamin D goes down. Okay, ALP goes high. So when vitamin D is low, ALP would go high, and vitamin D low itself tells you it's a case of rickets. That was the straight pickup. But I think some people are telling me the X-ray was also there. See, this is a normal patient, and this is a patient with rickets. Look at the classical changes here. This is the growth plate that you see over here. This blackish area, we call it physis or the growth plate. Normally, a growth plate is very smooth. But if you look at the physis in a case of rickets, see the changes. You will find it to be widened. So this is not that wide, this is very wide. You will find it to be splayed. Splaying means flattening. So this is bit curved. This is flat. And along with widening and splaying, you will find fraying. So fraying, I hope you can see this physis is frayed. It's irregular. This is so smooth. So normally growth plates are very smooth. They're curved. They're not that wide. If you find that widening, splaying and this fraying, that is where you talk of rickets. So this question was also a very simple one. Now some people are also telling me that there was some question on osteoarthritis of the knee, and then you were asked about some kind of a treatment, and I think you understand that knee has synovial fluid, and synovial fluid in the knee tends to contain this product called hyaluronic acid. So hyaluronic acid injections are like a known treatment for cases of osteoarthritis of the knee. Some people also say there was a question on the synthesis of hyaluronic acid by that enzyme hyaluronic acid synthase, that although goes into biochemistry to an extent is also not a very question. And then I have received the feedback that you had some kind of a picture where a patient had deformed bones with multiple fractures, and maybe there is a clinical picture with that blue sclera showing you the classical scenario of osteogenesis imperfecta. Osteogenesis imperfecta, you understand very well, collagen 1, which is present in sclera bones, by birth tends to be defective. So this is what gives you weak bones, blue sclera. So you find that blue sclera because of weak collagen, and you find deformed multiple bones with multiple fractures. That is where you talk of osteogenesis imperfecta. So that's the feedback as per my knowledge, uh, as per the feedback I have received. That is what I think was there in the exam. So it was very simple exam. It was all about your basics. Uh, a lot of things were just simply repeat MCQs from the previous exams. The MCQ was changed, but not the topic. So again, I would stress upon it that in case even if you don't get through and you are thorough with previous 2 or 3 year papers, trust me, the next attempt will be your last attempt. So please make sure that you go through all the recalls. At least the topics that have been asked should never be missed. And when you prepare, stick to basics. But for the time being, all those who have given the exam, I wish them all the best. My wishes are with them, and I'm sure you guys are all going to be through. And I'll be looking to see you, some of you, in the colleges I work in in Delhi. It's a lovely place to train. So clear up the exam and join up here. All the best.